So I'm a haematology consultant. Haematologists are specialist doctors who look after and investigate conditions that are associated with blood problems and also bone marrow problems, which is the factory where all the blood cells are made. So this can include conditions like anemia, leukemia, where you have too many white blood cells, a type of blood cell cancer, but also clotting problems where the blood's not sticky enough, like haemophilia, or when the blood's too sticky and patients can develop clots. Alan and I are just going to review a blood film of one of our haematology patients who's had some changes in their blood count from their normal, and we need to have a look at the cells and make sure that their disease hasn't become more aggressive and changed into something like leukemia. I like the balance between looking after patients and also spending time in the laboratory as well. What I particularly like about haematology is that you can do a lot of things yourself. So you can see the patient, take their blood sample up to the laboratory, look at the numbers that run in your lab, look at the cells under the microscope and come to a diagnosis. Pretty much everyone who comes into contact with any sort of a doctor will end up having a full blood count. And you can actually tell a lot, not just about blood conditions from a full blood count, but also other conditions like renal impairment or when people's livers aren't working. These can all be reflected in changes in blood numbers and also in appearances on the blood film. It's very multidisciplinary, so we interact not just with our laboratory teams, but with all other aspects of clinical care, nursing staff, doing education on the wards, orthopaedic surgical colleagues, making sure patients are fit for theatre, that they're not going to run into other complications, and also providing blood products for transfusion when people need those as well. How many guys do you think we've got to go? What do you think? So as a haematologist, we have our own patients that we look after directly. So from my interest is people with red cell blood disorders, which are usually inherited conditions. So things like sickle cell disease or thalassaemia, and those patients are directly under my care, and I prescribe and manage their treatments, for example, arrange their transfusions, etc. But we also contribute to the care of other patients in the hospital, for example, again, via the transfusion laboratory, running all the haematological tests that inpatients and outpatients that the GPs send in, and also providing advice and guidance for clinical colleagues. So another part of the job is that I come and see patients here on our day unit. So as I'm a doctor with a red cell interest, our day unit is specifically for patients with red cell disorders, so that's people with thalassaemia and sickle cell disease. So I'm just off to do a couple of reviews of a couple of my patients. So a patient who is a young girl with thalassaemia. So thalassaemia is an inherited blood condition that's present from birth and requires transfusions to sustain life. Unfortunately, this girl has had significant reactions to her blood transfusions, which creates a sort of a critical problem because she needs these transfusions to survive. But the transfusions, if anything, are making her quality of life worse. And we can set up a special panel in conjunction with the UK Thalassaemia Society, which is a patient organisation, to get experts from all over the world to take advice on this girl's case. And we've started a variety of new therapies, and they seem to have really improved her reactions to her blood transfusion to the degree where she's thinking about going back and completing her PhD. So this is Emma Prescott, who's my specialist nurse, who is my thalassaemia clinical nurse specialist and plays a massive part in keeping our patients well looked after. I've got big group of colleagues. That's one of the nice things about haematology as well, is that we do get to work in a really big, diverse team. So here in my District General Hospital, I have 3 consultant colleagues, 3 registrars, F2, and also all my laboratory staff, 3 specialist nurses, a psychologist, a family psychologist, and the paediatric team as well. That's my sort of close working group. Say if a patient needed to have their clinic appointment brought forward, Sade and I would have a look on my clinic lists and see where we had space and when we could slot that patient in. If I was on the wards, I might start Monday morning by coming in, getting handover from whoever was on over the weekend, making sure there weren't any urgent issues in the laboratory, like blood films that need to be looked at, or any results that need urgent review. Then we tend to do a ward round, review all the inpatients, any acute admissions. Then we've got, say on a Monday, we have our multidisciplinary team meeting where we all get together to discuss the patients, and then back to the laboratory in the afternoon to sign off my clinic letters, check any blood results from the day, and make sure there's no new developments over the afternoon. And as I say, I tend to do anywhere from sort of 2 to 4 clinics a week. I do teach on a core medical trainee course. With myself and another colleague, we've just set up a series of lectures that we're giving, going around the country as sort of a red cell roadshow, trying to encourage other colleagues to take part in, join our red cell subspeciality, shall we say.
Most of our patients are from ethnic minority.
Yeah, absolutely.
Yeah, and the donors are mainly Caucasian. Yeah. So developing antibodies is normally more high risk. I'm in charge at our site of one clinical trial, which is an international trial with multiple centres in the UK and abroad. And that's looking to see if we can reduce the amount of blood transfusion in patients with thalassaemia, because currently transfusion-dependent thalassaemia patients have to come every 3 weeks, and it would be great if we could either mean that they needed to have less blood or needed to come less frequently. So we'll be looking to see I've got the APOS. There's a lot of flexibility in how you construct your work. I'm very busy, but that's because I do a full-time clinical job, and I choose to do clinical trial work, apply for grants, and also do quite a lot of teaching. These are all voluntary extra bits that I do, and therefore I have to fit them into my job plan as best I can. But there's no pressure on people to take part in that sort of extra activity. One thing that is increasingly common in haematology is that it can accommodate flexible and part-time working, particularly for trainees. A decent proportion of trainees will have done some form of, especially the girls, will have done some form of part-time working. But I know a couple of blokes that are working part-time as well, because their partner's gone back into work full-time, and they're taking on that sort of childcare aspect as well. Blood groups, if people have developed a reaction to blood transfusion, then we do what's called a DAT test, which is a special type of blood test, which is looking to see if there's any of the antibody on the surface of the red blood cells. So it's a bit of not necessarily the most straightforward training to become a haematologist. So you do your standard foundation year, and then most people go on to core medical training and then sit their membership at the Royal College of Physicians. I then got my my registrar jobs at King's College Hospital in South London.
I took some time out to have my daughter. I took 9 months off for maternity leave, and then I went back to do my PhD for 3.5 years. I then took my Royal College of Pathologists exams. So you have to do 2 lots of postgraduate exams to become a haematologist. And then I got my consultant job here at the Whittington about 2.5 years ago. And I now work across 2 sites, the Whittington and UCLH.
Which is plasma. So I think
this is plasma. That's a different type of clotting product, a bit less specific than the ones in the other fridge. So for any medical students who are interested in a career in haematology, I would try and just go out there and get some experience. We're a friendly bunch. People are always welcome to come up to the lab, have a look at slides. If you've had an interesting patient, perhaps that haematologists you've been involved in, do come and have a look at their blood film, just because it can sort of tie things all together and crystallise it in your mind. As regards getting points for applications, there's always lots of audits and projects available in haematology. Audits of how the laboratory is working, how effective our interventions are all very important and all part of being a good and efficient doctor in the current NHS. Great, thanks very much, Faye. As you can see, all clinical trials involve a vast amount of paperwork, and it's very important to have a really good trials team to make sure that we meet all the requirements of the trial. So one of the great things about haematology is the long-term relationship we have with our patients. We can know them from sort of birth all the way throughout their entire lives. So you do really know everything about them. You know their family circumstances. You see them as a whole, not just as a diagnosis. What's particularly rewarding is when you have a patient come to see you in clinic who perhaps has been really unwell on the wards and has got better and is telling you how much better they're feeling. And that's the best feeling in the world. So haematology is a great career. I'd strongly recommend it to anyone. I think you can make it what you like. Even within haematology, there's so many different subspecialities that it really is like the world's your oyster.